So hi, everyone. Thank you for giving me the opportunity to be here today. So we're going to just be explaining what are the different corneal transplants so that whenever you encounter a doctor saying a DMAC, DSEC, PK, all of those terms, you kind of understand really what do they mean by all of those acronyms. So first, the cornea. So it's the outermost transparent tissue of the eye that has that dome shape. You can see it first. So it's like that dome shape layer in the outermost layer of the eye. Importantly for this topic, the cornea has 5 different or 5 different layers. So we can see here like epithelium, stroma, endothelium. We're going to go more into detail about them, but that's very important to be able to understand what are the different types of corneal transplants. Why is it so important? The cornea is because it provides the one of the refractive powers of the eye. So any damage to the cornea, it's very bad for the patient's vision, and that's why it needs to take care. Importantly, the cornea has no blood vessels, so that's why it's completely transparent. But if in the exam we see any blood vessels going into the cornea, that means that there's like severe inflammation or chronic history of a chronic inflammation or infection in the surface of the eye. And that means there's a severity of the eye itself, and also that affects what's going to be the outcome of the transplant as well, because any blood vessel into the cornea increases chances of rejection as well. Not having any blood vessels means that how we can question now then how is that the cornea has nutrition, how can it keep itself functioning, because every tissue in our body needs some kind of nutrition. So the cornea uses the tears as well as the aqueous humor in the inside of the eye to keep itself have the nutrition and the oxygen to keep itself working. As well, we see that many patients that come to our clinic with severe pain whenever they have some kind of pathology, infection, trauma to the cornea, it's like, why is it so painful? Why are they complaining so much? So the reason for that is that the cornea is the most sensitive tissue in our body. So the pain sensation in the cornea is 300 to 600 times greater than the skin. So that's why any insult to the cornea provides an excruciating pain for the patient. So let's talk about the different layers of the cornea. So in these 2 pictures, we can see it's just like a snapshot of a very small area of the eye. So we can see in the right side, if we take a snapshot of the cornea, which is that outermost transparent layer, we see that there's 5 different corneal layers. The outermost layers that you can see here, it's called the epithelium. That's the most outer layer. Just beneath it, there's a very thin layer called the Bowman's layer. And then the thickest part of the cornea, which is this one that you can see here in like a very light blue, it's called the stroma. That's form of collagen bonds within the cornea. And then there's 2 inner layers called the descendant membranes. That's like it's what we call a basement membrane. It just functions like a barrier between the inside of the eye towards the outside of the eye. And then we have the endothelium, which is the most inner layer of the cornea. That's just this layer here in the most inner part of the cornea. So this is very important to understand that the cornea has different layers to be able to understand what's the difference between the different types of corneal transplant. So in the evaluation of the cornea, the most important part is the slit lamp exam. Why? Because with that very thin slit beam of light that we create with the slit lamp, we're able to see every single layer of the cornea, and then we're able to evaluate where exactly is the pathology of the patient, if it's affecting epithelium, stroma, endothelium, which one is affected, or even if all of them are affected. And then that allows us to determine what's the type of corneal transplant that will be best for this patient. As well, pachymetry, that measures the corneal thickness. So that allows us to see if there's any corneal edema that it's affecting the vision of the patient as well. Topography and tomography, that measures like the corneal power, the curvature, the elevation, all of that allows us also, guides us also into what type of treatment does the patient needs to be able to provide them the best visual outcome for the patient. And the anterior segment OCT provides us a view or a snapshot as well of all the layers of the cornea, and it's very important for the corneal transplants, and you will see it further in the presentation. So the cornea can be affected by multiple things, starting for infections like corneal ulcers, which can end up causing scarring into the cornea, inflammation most commonly seen by herpes, injuries like laceration, abrasions, which can cause also scarring into the cornea, diseases, hereditary diseases like corneal dystrophies or ectasia like keratoconus, Fuchs, and others. And also previous eye surgeries can affect the cornea itself. Even cataract surgery can have a huge effect on the cornea because we're working between the cornea and the lens. So any ultrasound wave affects the corneal tissues as well. So it can cause like chronic edema, and then that can turn into chronic scarring as well. So there are 4 types of corneal transplant. We have the penetrating keratoplasty, what we call the DULC, DSEC, and the DMEC, and we're going to go over all of them. So this is just a picture to understand how do they differentiate one from another. So here we have a picture of all full cornea and all the layers of the cornea. So if we move to the left, we can see this is the gray shadow, shows what are the layers that are transplanted in what we call the PK, or the penetrating keratoplasty. So it's a full thickness. So the full cornea is the one that it's being transplanted. In what we call the DULC, it's just that anterior layers of the cornea. So we see that the endothelium and the stroma are the ones that are being transplanted. And then in what we call EKs, that's endothelial keratoplasty, which are divided then into DSEC and DMEC, are only those inner layers that we see here in gray. Sorry, here in gray. So let's talk about a little bit further about each of them. So penetrating keratoplasty, so that's the full thickness corneal transplant. So every single layer of the cornea is been transplanted. The indication for this type of corneal transplant is commonly seen for patients that have keratoconus or corneal ectasia, but usually the patients that have a full thickness corneal scar secondary to their keratoconus, or a very thin cornea where then DULC, which we're going to be talking about later, it's not going to be effective. Or for example, patients that have corneal ulcers that result into a full thickness corneal scar, same patients that have trauma with a full thickness corneal laceration, all of them will only be able to have a full thickness corneal transplant to be able to provide them the best visual outcome. I'm going to show later how the surgery kind of looks like, but for a postoperative management, which most of you help us in this part, so corneal PKs do induce a very high astigmatism into the cornea, just because we have to suture that tissue into the patient's cornea. So about 3 months or a little bit later, we kind of guide ourselves with topography with that curvature that is presented by the topography, and that allows us to guide ourselves which sutures that have been placed can be removed to be able to start rehabilitating the vision of the patient. So that's why you may see that the doctors ask for topography every month after a certain time of the PK, is just to guide themselves to be able to remove the sutures. So when all the sutures or most of them are removed, or when the patient has a stable astigmatism, then we can proceed to perform a refraction. And then from the refraction, we can then have the patient use glasses or the scleral lenses to be able to provide them the best visual acuity possible. As any surgery, there are complications after, or there are possible complications. We can have wound leak, so meaning that that interface between the cornea that was transplanted and the patient's cornea hasn't sealed completely, and then there's like some aqueous coming out of the eye. Also graft dehiscence, so meaning that the two tissues are not well aligned, and then it's causing some displacement of the of the tissue, increase in pressure, infection, and like any other transplant, rejection or failure. So rejection usually is that the human body or the patient's body is not accepting that transplant. So it's kind of, it starts to produce inflammation, swelling in the cornea, and that's a sign of rejection. And failure is known as more like the transplant never started working, and it's not functioning within the eye of the patient, or when there's a rejection and there's not able to be treated, or that inflammation it's chronic, then the graft becomes completely swollen and then it completely fails. So we have to proceed to other transplant. So here just an image of how it works. So we can see here, so this is the patient's, for example, a patient's cornea. So what we do is that we call it a trephination. So we kind of cut in a specific size depending on the scar and the patient's cornea. We kind of just cookie cut that cornea, and then we transfer, then cookie cut the transplant cornea as well, and then we suture the cornea into the patient's eye. And you can see here in this image how we do this kind of individual radial sutures all along the transplant. And that's why all of this can produce astigmatism, and then they need to be removed little by little as time goes by. So DALK. So DALK stands for deep anterior lamellar keratoplasty. So deep anterior, so anterior is those anterior layers of the cornea, meaning that if you look here in the upper right, you see it in pink, is just those anterior layers, and we leave behind those inner layers of the cornea of the patient. So it's kind of a partial thickness corneal transplant, but just of those anterior layers. And what is the difference between this PK and the DALK, or why will we choose one versus the other, is because this type of transplant has a significant decrease of risk of graft rejection. Why? Because that endothelial layer of the patient's cornea is the one that produces the proteins so that the patient rejects the transplant. So that's why there's a lower risk of graft rejection whenever this type of procedure is performed. So if we can choose one versus the other, we usually try to perform a DALK. But the surgery is a little bit more difficult. So sometimes we try the DALK and then we have to convert to a PK if there's any change in the surgery that we need to convert. Indications for this type of transplant, it's usually when the patient has a normal functioning endothelium, so that inner layer has no problem, is not involving any scar, and is well functioning. Commonly done in patients that have keratoconus, as I mentioned before, but usually some patients that have keratoconus have a corneal scar. We just have to make sure that that scar is not full thickness. And as well, patients that have had corneal ulcers, which have a scar, just make sure that they're not full thickness. And in this second picture here is just kind of showing how during the surgery, the difference between the PK and the DALK is that we have to remove during the surgery those anterior layers. During the surgery, there are different techniques. I'm not going to go into detail of that, but we either used air bubbles or we do like a manual dissection of the tissues until we're able to get into this. We're able to see that we haven't perforated this inner layer, and then we're able to suture as well that graft over the patient's cornea. So post-op care, very similar to the PK, doing topography and tomography just to follow up that astigmatism and be able to remove the sutures when suited, just following that astigmatism as well, doing a refraction. And in this case, also the anterior segment OCT is very important because it's allowed us to see if there's any space between the donor and the patient's cornea. If there's any space, sometimes the patient needs to go back to the OR to kind of have that spaced control, or kind of that remove that anything in the interface and be able to place that transplant back. Complications, it's after the surgery. One of them is called double anterior chamber. That is what I just said, there's like a space between the corneal transplant and the patient's cornea. Stromal graft rejection, like any transplant. Interface haze, that means that there's like a haziness between the transplant and the patient's cornea. Inflammation, infection, increase in pressure, and graft dehiscence, also seen in PKs. So DSEC. DSEC stands for Decimal Striping Automated Endothelial Graftoplasty. I know it's a big, long name, so we prefer doing saying DSEC, but it helps us to understand what are the layers that are being transplanted. So endothelial keratoplasty, just think about those inner layers. So we can see here in this picture on the top right, this pink area here shows that those are the inner layers that are being transplanted. So we also call it like a partial thickness transplant of the inner layers of the cornea, but in difference from the DMEC, which we're going to be talking about later, is that the DSEC has a very slight layered of the posterior stroma. So it means that it has 3 layers: the endothelium, which is the most inner layer, the one on top of that, which is the desmate, and a very thin part of the posterior stroma. So it's a little bit of a thicker transplant. And what's the difference between the DSEC and the DMEC is that the DSEC has a slower visual rehabilitation than the DMEC, and usually the visual outcome is a slightly lower than the DMEC. Indications for this type of transplant is any patient that shows that there's not well-functioning endothelial cells. So like that inner layer of the cornea is not functioning well. Like, for example, patients that have Fuchs endothelial dystrophy means that those inner layers are not functioning well, meaning that they're not, for example, patients can show with corneal swelling because the pumping system within the inner layer is not functioning well. So we can just replace that layer in the cornea that's not functioning well. Also, another indication, we call it bullous keratopathy. That means that's associated with patients that have had cataract surgery or any other eye surgery, and then that they develop a chronic corneal edema that doesn't heal. So we call it bullous keratopathy, and that also affects that inner layer of the cornea. And then more complicated cases, like patients that have a phakic anterior segment IOLs, post-glaucoma surgeries, or patients that have had multiple eye surgeries that have affected the cornea, then the DSEC is a more stable tissue to be able to place in those kinds of eyes. And it's also because of the surgical techniques, the DSEC, it's easier to be handled in an eye that has had multiple surgeries. It's not suitable for eyes that have that have like any corneal scar or any thinning, just because it's just treating those inner layers. Surgeries, I'm going to be talking about in the next slide. But here you can see that this is kind of a slit lamp photo, that you can see this kind of circular layer, circular line across the cornea. That's how it really looks, the DSEC on a slit lamp.
So that's not sutured in that, right? So
This one, there's no suture, no. Exactly, I'm gonna show that in the next slide, but there's no suture in this kind of transplant. I'm gonna show, but we put a air bubble underneath it, and then the patient sleeps facing up for a couple of days, and that allows the tissue to kind of heal itself inside the cornea, and then attaches. But as we will see, some of the complications for that is that it can detach, and then we'll need other treatments for that. And then here we can see why the anterior segment OCT is important in these cases. Here we see that there's like this extra tissue kind of lining in the interior part of the cornea. So that's that corneal tissue that was transplanted into the patient. Just kind of keep an eye of how it looks in the anterior segment OCT and how it will differentiate from the DMEC. And as well, like any other post-transplant patient, for post-operative management, we have to check the pressure because these patients, since we do place a gas bubble inside the eye, that can cause the eye pressure to go high or up, and also do a refraction after like surgery, about whenever 4 to 6 weeks after the surgery. Complications. So this comes along with, if we don't put any sutures, how can that hold? So the patient can come up to post-op care, and we can see what we call a transplant or a graft detachment. And that's why we follow the patient with the anterior segment OCT, because we are able to see if there's any light detachment of the periphery or the center, depending which area. And depending on how much is that graft detached or where exactly is detached, then we decide if we have to do another bubble, or what we call a rebubble, to be able to reattach or bring that tissue back into the patient's cornea. As any other transplant, there's a risk of failure, rejection, pressure high, infection, and inflammation. So this is a little bit about the surgery. So when this is kind of the disc that we cut for the corneal transplant, this is how it looks. And this is a injector that not everyone use it, but we use it pretty often here. It's called the endoserter. And this is kind of folded. And then you can see it here on the top right. So it's kind of a little tube. So with that tube, we kind of go into the inside of the eye, into the anterior segment, and then we inject that tissue, and that tissue kind of opens up into the inside of the eye and lays itself over the iris. Once that's kind of open up, sometimes we have to do some maneuvers within the surgery to be able to let that tissue to open. And then after that, we inject a gas bubble under it, and then it will push it into the patient's cornea. So this is kind of a very this is kind of an image of what we see day 1, day 3 after surgery. We see this is the graft here, this kind of linear circular tissue in the cornea, and then this is the gas bubble that's pushing the transplant into the cornea. We use SF6, yeah, 20% SF6. We don't leave a full bubble inside the eye. We usually leave it about, I will say, like an 80% of the fullness of the anterior segment, just because it can create what we call a pupillary block, so that it just kind of blocks the angle, blocks the pupil, and then the patient will come with a pressure of 60 or plus, and then that's very bad for the patient, but as well for the survival of the graft as well. So then DMEC. So DMEC is a little bit similar to the DSEC. It's just that different kind of layers are being transplanted, and as well the kind of patient that will have a DMEC surgery done as well as different. And the visual outcomes is very different. So in a DMEC, it stands for descendant membrane endothelial keratoplasty. So that means that only the endothelium and the descendant membranes are the ones that are transplanted. So that means that the tissue is very, very, very thin. There's no stroma in that tissue. So we also call it like a partial thickness transplant of the inner layers of the cornea. What's the difference between the DMEC and the DSEC is that the DMEC does provide the patient a superior visual outcome after the surgery. So patients can have even a 20/25 vision within months, like 2 to 3 months after surgery. So it's a very good outcome from a corneal transplant. Indication. So usually the most common patients that have this type of transplant are the Fuchs, patients who have Fuchs endothelial dystrophy, because in those patients, that's the only layer that's affected. The rest of the cornea is very healthy. So we just want to just replace that layer that is not functioning in that patient. Also, sometimes patients that have bullous keratopathy, but depending on how long that edema has been in that eye, and we have to take in consideration other things. Sometimes I call this surgery for like a virgin eye, that there's no surgery that has been done previously, just because during the surgery, you have to have a very specific things to happen to be able to be a successful surgery. So it's not suitable for eyes that have corneal scarring, or eyes that don't have any iris like aniridia, because you need that iris support to be able to do the surgery well, and we will see it in the next slide. So in these pictures here, you may think, what's this blue thing? So this blue circle here is the transplant. It's blue because during the surgery, we place tryptophan blue, so it's like a stain for us to be able to see the transplant and know if it's in the exact location, if it's in the exact orientation. So that's a way for us to guide ourselves during the surgery, but you won't see it blue the next day, it goes away. And also they have developed this, what we call a stamp. It's either an S stamp or an F stamp that allows us to see if it's in the correct orientation. Because if we place it in the incorrect orientation, for example, if the endothelium of the transplant, it's over the stroma, that transplant is not gonna ever work, and the cornea will decompensate. So that's not good at all. Postoperative management. So it's very, very important, the anterior segment OCT in this cases, because it's a very thin transplant. So sometimes it's very hard to see in slit lamp exam, and more whenever the patient has edema or has a gas bubble. So the anterior segment OCT kind of guides it into seeing if there's any detachment of the transplant. As well, pressure management, pachymetry, refraction. Complications, same as the DSEC, there's a complication of graft detachment. Usually in DMEC, the graft detachment, has a higher percentage. And as times goes by with the surgeon's expertise, that detachment rate can decrease, but it's more common than in the DSEC because of how thin is that tissue. So the anterior segment OCT kind of guides us to know how much is the detachment, if we have to rebubble or not. We have the other same complications: failure, rejection, increased pressure, and infection. So this is a pretty good way to show how the surgery goes. So usually this tissue tends to roll itself, like you see here, it kind of rolls towards the inside. So when we inject the tissue into the anterior segment, it becomes a roll. So what do we do to be able to unfold that roll? So we have to, the anterior chamber has to be very flat. So that's why we need that iris support. So patients that don't have iris can't have this surgery, because we need that iris support to be able to unfold the tissue. And we call it it's called like a tapping dance over the surface of the cornea. So you see here, this is called like a cannula, and we do different tappings over the cornea, and that creates like a fluid wave inside the eye that allows that roll to open. Once that roll open, it creates like this disc inside the eye, and then we're able to place that bubble, gas bubble underneath, and that will push the transplant over the under the cornea of the patient. So this is how it really looks in the surgery. So we have that blue roll. It's not blue, but we use the stain to be able to see it. And then here we just do a lot of tapping techniques to be able to unroll it. And then this is how it looks after the unrolling. And this is just an OCT image to show how we can see a detachment. So these arrows here point to what we will call a peripheral detachment. It's pretty shallow, but there's a detachment there. So probably in this patient we can observe, but depending on how much is the extension. And then you see after it has reattached, there's this very fine line. It's not seen anymore. It's kind of attached to the cornea. But with this image, you're able to see how thin is this transplant. It's kind of almost very hard to see within that anterior segment OCT. So it's good to see the difference of the thickness in the transplants. And I'm just going to briefly mention keratoprosthesis, since we do have patients in our clinic that can present with this type of transplant. So keratoprosthesis is it's an artificial cornea, so it's a prosthesis. So this is how it looks in the patient's eye. And the prosthesis, it's kind of built up into different things that come together and create this artificial cornea. So we have like a front part or an optic that gives that refractive power for the patient. Then we have a cornea graft. This is, we usually use what we call an irradiated cornea tissue. So it's not a fresh tissue, that it's also placed in the kind of the prosthesis. And then we have like a back plate that what has those holes in there. It can be out of acrylic or it can be out of titanium. And then we have this locking ring, which kind of keeps everything together. Okay, so it's kind of an assembly. The most common one that is used is called Boston keratoprosthesis. But the problem with this type of transplant is that the patient has to have a lifelong commitment to be able to follow them, because they do have the very, very high risk of multiple complications within years after the surgery. So it's very, very important for the doctor to be able to talk to the patient and let them know that this is a lifelong commitment with the follow-up and the patient. So there's no risk of rejection, but there's a very high risk of complications. So for this, we consider it as the last resource we will kind of offer to a patient because of the multiple complications they can have in the future. Indications, so patients that have had multiple transplants that have failed, or very severely diseased eyes, or severely diseased corneas, that you know that if you place a PK, it's not gonna work and it's gonna fail very quickly. So those are usually the patients that we considered a keratoprosthesis, or we can call it a K-Pro as well. The surgery is very, very similar to PK, so a full thickness corneal transplant. But nowadays, with everything that has been shown in the literature, they're usually done in combination with the retina specialist, the glaucoma specialist, to try to decrease the postoperative complications. So it's a very big surgery as well for the patient. For postoperative management, as I said, it's a close long-term follow-up. And we know Tina knows more than all of us together about this part. And patients do need a very long-term topical antibiotic and steroids as well. Some of them do have use of contact lens. So they have to come every other time or every other month to have that contact lens removed and replaced. And also the prosthesis cleanup as well. Complications, there are multiple. And whenever we talk to the patient, we always tell them it's not a matter of when it's going to be the complications. It's a matter that you're going to have one of them or more than one. So that's why they need a very long follow-up for their lifetime. One of the most commons that we see is glaucoma. So that's why we combine the care with a glaucoma specialist. And usually these patients also have a glaucoma valve placed during the surgery. Also endophthalmitis, because this is just a prosthesis kind of placed in the eye. So there's an easy entry for bacteria, fungal, virus to come into the inside of the eye. Keratoprosthesis melt, that means that cornea graft that we put in the surface can melt out and then we have to replace it. Patients, if they have a trauma to the eye, that prosthesis can come out. It can also happen in a PK, but it can be seen more commonly in a prosthesis. And also posterior segment pathologies, like retinal detachments. So, when we think about transplant, it's like, why an endothelial transplant versus a penetrating keratoplasty? So I show what are the indications, but it's also important to understand what are the benefits of one versus the other. So the endothelial keratoplasty, we also call them EK. So they're much less invasive, as you can see in the surgery part. There's a lower risk of rejection, both for DSEC and DMEC. There's a much faster visual recovery. Instead of a year, it's within months. Better visual prognosis as well. A shorter postoperative care. less induced astigmatism because we don't have to suture the transplant to the eye. No need of multiple visits, like frequent multiple visits, to be able to remove those sutures and treat that astigmatism, and many less intra and postoperative complications. But there are patients that there's no other option, and then the ones that we can offer are the PK or the DUC. For example, patients who have significant scarring, thinning, perforations, or very high astigmatisms that cannot be corrected with contact lenses, or that they don't tolerate the contact lenses anymore. But one of the good things about PKs, they don't need to lay flat after surgery for 2 to 3 days. And thanks for everything.